Hello and welcome to this, which is a new trial of disseminating information to staff in critical care and theatres regarding the developing COVID situation. I think we're finding that a lot of the policies and protocols are good, although there are some tweaks, some tips, some adaptations, and we thought this is probably the best way to bring some of that information to you. Hopefully, like I say, it'll be a bit more accessible, a bit easier than reading your emails. And we'll also try and highlight some of the documents that have popped up in the last week in case you hadn't already heard of them. This update is based on information we've gained from the feedback we've received via the QR codes on the LOCSIPs and also through various WhatsApp groups and conversations with colleagues. Today's Monday the 30th and we'll hope to have another one next week as well. My name's Andrew Hughes. I'm one of the anaesthetic consultants here at the Glenfield. I'm here with Sam Hanajuma, one of the ITU consultants. So, right, let's start with the Marriott team. What can you tell us about the Marriott team? We're finding difficulties tubing on the ward, is that right?
Yeah, so what happens on the ward, we created this checklist and LOCSIP, which you have to make sure you've gone through step by step, because when you're intubating someone in the anaesthetic room, you have a backup equipment. Unfortunately, when you go downstairs, you have enough equipment to do the procedure safely, but you need to make sure that's all in working orders, like tube, laryngoscopes, checking blinds, and that's why you have to go through the checklist religiously, because you're in a distant environment and you wouldn't have an equipment to back you up.
Right, okay. So making sure we use the checklist. I know some of the colleagues have had some difficulty when they go down there, they realise actually the room's full of furniture, you're intubating on a normal ward bed, the mattress can slide down. So it can be quite tricky. So if possible, transferring them up to theatre.
Ideally transfer everyone to theatre 1 anaesthetic room. That's where you're going to have a prepared anaesthetic room to do all the intubations. But in certain circumstances that you can't move the patient for different reasons, either logisticals or patient related, then you might have to do it down there. You need to take the COVID intubation trolley with you downstairs, which will have all the checklists and all the equipments. There will be 2 of them in intensive care, and there will be 2 or 3 more intubation trolleys in different parts of theatres.
Great. Okay, great. Someone experienced over the weekend, some of these patients are on CPAP or NIV, and then when you turn it off, they desaturate really rapidly. So, you may need to have a sort of think about managing the CPAP and whether you take it off just before you intubate or how you're going to pre-oxygenate these individuals. So that's something to just bear in mind. Also, a lot of them don't have battery or gas supplies. So when you do disconnect them or turn them off, there isn't often anything to keep them going. So don't fall into that.
Yeah, my opinion, the safest way to transfer someone in on a non-rebreather, 10 to 15 litres oxygen. If you can't do that, then maybe you should intubate them downstairs.
Great, okay. Right, Mapleston C circuit, there were some problems with that.
Yeah, just need to be careful because you need to put parts together very tightly and make sure they're safe and secure, because once you start to back, sometimes the whole circuit falls apart. And the other thing that you need to make sure is the filter is the nearest part to the patient to keep everything else safe from contamination.
These are the yellow viral filters?
Yellow viral filters or the green HME filters.
Great. So the green HME filters actually do provide quite a lot of protection.
They're very safe. The yellow viral are 1 in 10,000% a bit safer. So once you PPE it, the HME is quite safe as well.
Well, that's pretty good to know, because we are running a little bit short on those yellow filters. CO2. Now we're having some issues with some of the CO2 stopping working when we're down there. So what was the problem there?
Yeah, so that's why I brought this L-shaped battery pack, because you have to take this with you if you're going to use the end-tidal CO2 on the monitors. The battery supply for the end-tidal comes from here, not from the block itself. So you have to click them together, otherwise you will not have an end-tidal CO2 for your transfer or intubation.
Great, okay.
These will be available on ITU in different places. They might be on charge at certain points, but you should have one with you before you go down.
Great. And that's and we're using the sample in line with the orange screw connector into those particular monitors, not the ones from theatre. Okay.
My advice, if you intubate someone in theatre and you're going to transfer them very quickly, maybe you shouldn't use end-tidal CO2, like what we do with the cardiac cases. We transfer them very quickly.
Just to sort of wrap it,
to avoid disconnection and contaminating circuit and exposing people to risk.
Okay. Now, controlled drugs, we've come up with a plan to, if you need any controlled drugs to take with you to intubate patients on the ward, we're getting them from the Theatre 1 drug cupboard, because as theatre staff can find that it's a bit easier to manage one location where drugs are being used from. So use Theatre 1 drug cupboard. We've got some walkie-talkies now, quite a lot of them, haven't we?
Yeah, we have a lot. There will be a stack in the anaesthetic resource room with 6 of them dedicated to the intubation team. Please take yours on the start of your shift, and the leaving team leave their back on charge, so we can keep swapping them around. Keep it on channel 6 so you can communicate with your team and with the consultant intensivist in charge. Okay.
And I know we've tried them out this morning, and from the anaesthetic resource room, we can hear you loud and clear when someone's over in the hybrid theatre, yeah. So good range on them. Great. Double gloving was another thing. We've done a lot of training last week. There were some varying practices with double gloving. At the end of the video, we'll show you what we mean by double gloving. That essentially, you put the glove on, one glove on first, then the gown, and then the second glove over the top of that gown. Now moving to the theatre space, there is a process at the sort of various locations for donning and doffing. And again, what we'll do is at the end, we'll show you a walkthrough of the spaces where you're going to put your stuff on and also take it off at the end of your shift. Now, ventilators. There's been a lot of discussion about using anaesthetic ventilators for long-term ventilation, and in fact that's an off-licence use of the ventilator. And I know Michael Schupp, one of the other consultants here, has been in communication with GE and Draeger. So he's done a brilliant job of summarising a lot of the recommendations, so I'll sort of point you in that direction. But a couple of specifics was soda lime, bit of anxiety about that.
So the soda lime is the main concern because we might exhaust the resources, so recommended to use 6 to 8 litres per minute flows as a compromise between using soda lime and the flow of the gases.
Okay, so we're preserving the soda lime as much as possible. There's not been any discussions about using isoflurane for sedation just yet. We think we've got enough.
Not yet. There's a discussion. It's an ongoing discussion. Yeah. But at the moment, we'll keep it with the propofol and the other TIVA drugs.
Great. So we're removing the vaporizers from the back bar. The anaesthetic machine usually does a self-check every 24 hours. We've been told that we can potentially override that and run for 72 hours if need be, but that will need some alternative ventilation for that period of 15 to 20 minutes of the self-check. And we're thinking either an Oxylog or a Mapleton C, but of course we need to think about all the precautions about clamping and aerosolizing procedure for that. A couple of other things, ABG machine, there is a sort of designated COVID ABG machine, and that's in between theatres 1 and 2 in the corridor area. There was some discussion about some of the other procedures that you need doing when people come onto ITU other than the intubation. So what are we thinking needs doing in addition to intubating?
So we'll be very helpful when our colleagues intubate these patients to put an NG tube at the same time after intubation, a central venous catheter, and we would kindly ask if it's possible to go into the left internal jugular, and a urine catheter. And we're planning to have an X-ray machine available in the anaesthetic room in Theatre 1, so we can have a chest X-ray after these procedures.
Great. And was the reason why it was the left side you want to put the line in?
So we want the left internal jugular to be used because we can use the right internal jugular in the future for these patients if they need ECMO or renal support therapy.
Great. Okay. One other document that's come out is the team at the Royal has adapted some theatre action cards. They're red colour-coded action cards. And I think they came from London, but we've adapted them for local use, so they'll be around, so do use those. It sort of helps you to the sort of things you need to consider when dealing with patients who are coming for surgery, not necessarily for ventilation and critical care. The last final things to mention, some tips coming from other staff about using microfoam tape on the new respirators. The mask can put a bit of pressure on the bridge of your nose and on your cheeks, and some of you will have seen those pictures of the Italian doctors with the bruising there. So maybe cut little bits of microfoam out to just support the bridge of your nose and any bony areas, obviously making sure it's within the mask itself and not disrupting your seal. The wellbeing area is just behind us, actually, the anaesthetic resource room. That's pretty well stocked now. Lots of donations coming in from outside of UHL. So if you do get some downtime, do pop in and help yourself to biscuits and a cup of tea or a coffee. We've also got a debrief tool. So if you're not used to doing debriefs, there's a take stock debrief card that's part of the documents that are going out, the action cards. So if you think about maybe starting to use these debrief tools and feeding back some of the information you gain from your debriefs to Sam or one of us to put together in one of these videos. But otherwise, I guess everyone's just saying stay as safe as you can. Keep the feedback coming either through the QR codes. You can just scan them with your normal camera on your phone. It brings up an email template to Sam, or of course just catch us in person. All right. Thanks very much.
Thanks.
Cheers. I want to draw your attention to the Public Health England guidance for the removal of personal protective equipment, particularly step 2. At the end of step 2, when you take the gown off, you're actually rolling contaminated sleeves over the back of your hands, of which you've already removed your gloves. So this is the reason why we recommend 2 gloves. So you take off the outer glove, then the gown, and then the underglove, and then also sterilise your hands with alcohol gel after that. This is to clarify double gloving technique. First put a glove on, followed by the gown, followed by a second glove, and this means that when you doff your PPE, you have a second pair of gloves underneath after you've removed the contaminated gown. So the donning area is opposite the consultant's computer room in the main corridor. The doffing area is actually the scrub room for Theatre 1, so you'd have to go through the anaesthetic room for Theatre 1, turn to the right and go through the door, which would have a sign on it saying doffing area. And then once you've doffed your gown and gloves, you walk outside into the corridor where the male's changing room is, and here is where you would take off your mask and visors. This is just a rundown of the theatre action cards. These hopefully will be in your clinical areas, but if you can't find them, then feel free to just pause on any one of these slides. They're going to be up for 2 seconds each. Here is the summarised guidance from GE and Draeger, kindly put together by Michael Schupp. That's it for today. I hope you found that useful. Let us know if there's any feedback you have over the following week, and we shall see you again next Monday.